On 28th of July, we are going to celebrate World Hepatitis Day, and this press conference is one of the events leading up to that special day. We wanted to take advantage, obviously, of this conference, and in that context, we really are very delighted to see the increasing attention to hepatitis. There have been many events on hepatitis C specifically, in the context of this conference, much more so than in any of the previous conferences. And that there's really a very good reason that the attention is getting much stronger and much more visible. You may know that hepatitis C is a disease that affects many people in the world. We estimate there's more than 180 million people infected, and that between 130 and 150 million people are basically chronically infected and will sooner or later require treatment. Before I introduce the other speakers, I would also recognize that this press conference has been prepared by our communication colleague, Glenn Thomas, who was tragically killed in MH17, and I would like to recognize and really have a moment of silence. Thank you.
All 194 countries represented at the World Health Assembly endorsed a resolution for very comprehensive action, both at a global level and also in countries, to address hepatitis. And some of the very interesting new developments in that resolution is a very strong call for supporting scale-up of treatment, which includes initiatives to improve access to affordable and quality medicines. There is also a call for work to be undertaken to actually look at the actual economic impact of hepatitis globally and in different communities, and what the feasibility is of actually eliminating hepatitis.
Well, a very important early part of the WHO response is the development of management guidelines for hepatitis B and C. And although guidelines for these conditions exist in high-income countries, until recently there was nothing for low and middle-income countries, despite their very high burden of disease. And this is also partly because the treatments that were available, particularly for hepatitis C, were costly, difficult to administer, difficult to monitor, and not well tolerated. The big change is now with the development and approval of a completely new class of oral drugs, the DAAs, the directing-acting antivirals, which can not just treat the virus, but offers the potential for cure in a large majority of patients with just 12 to 24 weeks of treatment, that are easy to take, simple to take, and well tolerated, and most importantly, offer the potential to be more widely available and at lower cost in the low and middle income countries that need them most.
I think it's pretty simple. We're at a moment in time, these new drugs are available and hepatitis C is curable. The people who need to be treated predominantly in the world are people who inject drugs. There are exceptions in other countries, but in many places it's people who inject drugs. A key issue is that we do not provide care to these people properly. This can be done. People who inject drugs are open to care. They are not a difficult population to manage. I have many, many years of experience of treating people who inject drugs for hepatitis C. When I first started to do it, people said, surely you don't treat active injectors, they're unreliable, this, that and the other. It's simply not true. There is stigma, there is discrimination, and in many, many places in the world, real problems with the law that make it that people who inject drugs cannot access health services. It's not that they don't want to, it's what we do in how we present them, both due society constructs and as well in places like Australia where we have a reasonably open health service system, we don't provide those services in the right places. The models tell us that if we treat people who inject drugs, active injectors, with these new medications, we can eliminate hepatitis C. They need to be combined with harm reduction programs, needle and syringe programs and opiate substitution therapy. Many places in the world don't have these. But if we provide these health services in places where people who inject drugs are, in community-based settings, it will be entirely possible to eliminate hepatitis C. In Melbourne, we have primary healthcare settings where myself and colleagues, as well as doing treatment in the big clinics, I'm a infectious diseases physician and work at the Alfred Hospital, but as well in doing the clinics there, if you take those clinics to the communities, you can treat people who inject drugs easily. They like to go there. It's a one-stop shop. They can get their needle and syringes. They can get their opiate substitution. They can get advice on housing. They can get counselling. They can get a shower. They can get clean clothes and shoes. This is not difficult. The difficulty is that we don't choose to implement it. So this is a real possibility. We have a moment where we have cure. Combined with quality harm reduction, we can do an enormous amount over the next 10 to 15 years.
It's wonderful to think about how to start curing people who are in desperate need, but these drug prices are completely unacceptable, and I think of us as not so civil society anymore. The benchmark of a US-based price, $1,000 per day, if companies offer a discount, this is not the proper benchmark. The real benchmark should be how much it costs to produce the drugs, along with a package of diagnostics, monitoring, and care. And there was a wonderful poster here by Andrew Hill and colleagues that says you can generically produce, with profit and sustainability, a treatment course for people with hepatitis C, regardless of their HIV status, their liver disease status, et cetera, for less than $300 a year. So I think it's time to look at patent barriers, IP, and what the real pricing benchmark should be based on. Even the classic cost effectiveness data supports unsustainable and unacceptable and extortionate pricing.